Ladies and gentlemen, next is a very important session that features exclusively on pediatric cardiology. Our opening speaker of this session is Professor Anita Saxena from the Department of Cardiology, New Delhi. Professor Saxena joins us this morning to deliberate on issues in adults with congenital heart disease.
Thank you. I would like to begin by thanking the organizers for inviting me here. We are just going to now go on to something to do with congenital heart disease, which is very different from what we've discussed in the morning. Congenital heart disease in adults is also given the name of GUCH, or grown-up congenital heart disease, by Jane Somerville from UK. And when we talk of adult CHD, very often you will find GUCH being used interchangeably. So the population that we are likely to see as adults with congenital heart disease would be either unoperated patients or those who have undergone some sort of surgery, whether it is a post-operative tetralogy or a VSD, or those who did not undergo a correction but had a palliative kind of a surgery, for example, a shunt operation when they were small. And we also have a set of patients who are considered inoperable, or their anatomy is too complex to have undergone any surgery. So what do we expect in adults? The common defects which have a good survival are likely to be seen in adults who have not been operated. That could be a large ASD, the most common lesion actually. Then some VSDs which are not very large. PDAs again not very large. Pink tetralogies are not uncommonly seen in our country in adults. And then coarct often goes unnoticed because we often fail to feel for the femoral pulses and the patient present with hypertension. Mild obstructive lesions like aortic stenosis, pulmonary stenosis will also have a very good prognosis. And then we also unfortunately see a subset of Eisenmenger syndrome, which simply tells us that our system or health system for congenital heart disease is still not good. And therefore we are left with very large VSDs and PDAs who go on to become Eisenmenger. We also see Epstein anomaly, which we know has a relatively good prognosis, although it is uncommon, but when it comes to adult, we do see adults with Epstein's anomaly. And then we have a small percentage of adults with those who have very complex abnormalities, who have been lucky, who have been exceptional survivors. So this is a long list of diseases which you are not likely to see in adults, but yes, a small percentage of adults may have this kind of congenital heart disease, which includes TAPVCs and truncus arteriosus and the complex names. So what I'm going to discuss is to tell you what constitutes adult CHD in India, another developing part of the world, which is different from what you're going to see in West. What are the key challenges that we face as pediatric and adult cardiologists, and what would be the opportunities? So our GUCH population or adult CHD population actually consists of two main groups: the unoperated patients, because they were never diagnosed, and we have inoperable patients. Surgery is a small group of, or post-op patients are really a small group. And this is our data of the last 1 year in our outpatient department. And as you can see, ASD is the biggest chunk of these patients. VSDs, which are not very large or which were small and now they are producing aortic regurgitation, etc., are seen in about 9%. And surprisingly, cyanotic heart diseases are also not uncommon. We see about 9% of tetralogies and 3.7% of Epstein in our series. We also still continue to see about 5% of Eisenmenger. This is the data that I had in 2005, which was almost similar. That time also we used to have 5% of Eisenmenger. In 2014 and 13 also we see about 5% of Eisenmenger. And you can look at the slide that the post-operative group only forms 14% of our patients which are seen in the outpatient department of All India Institute of Medical Sciences. So typically diseases which allow survival to adulthood are seen in adults or in GUCH patients, that is ASD, aortic stenosis or other aortic valve lesions, small shunts, pink tetralogies and mild obstructions. Then we also see patients with Eisenmenger syndrome which have not been operated in childhood, now they become inoperable, and then we see some exceptional diseases which are very serious diseases which are very, very small. So although these exceptional survivors are a small percentage, but we do see from time to time, and here is an example of a transposition surviving to 22-year-old, and you can see that the right ventricular angio is actually filling aorta and there is no VSD. So this patient had a large ASD, was quite blue, but survived to this age. So these are really exceptional survivors, although they take us by surprise, but they are not the majority. However, in India, the population being so large and the birth rates being so high, that we expect that even these complex anomalies are not uncommonly seen by adult as well as pediatric cardiologists. And even if we take survival of only 5% who would survive with these abnormalities or these complex abnormalities, we still are likely to see a huge pool of these complex anomalies. So although they are rare, but they are still seen in India. That's the point I was trying to make. So what are the issues or what are the challenges? I think as congenital heart disease is a disease present since birth, we often see ventricular dysfunction, heart failure during adult life, pulmonary hypertension, high pulmonary vascular resistance leading to Eisenmenger syndrome. Then those who are blue, we tend to have these complications of long-term cyanosis, which could be cerebrovascular accident, hematological problems with more bleeding and more thrombosis, and then renal function abnormalities, urate abnormalities, etc., etc. Infective endocarditis always remains a risk for all these patients, and arrhythmias, even those who have been operated, tend to develop arrhythmias in later life. So we have to be watching them for arrhythmias even if they're operated. The non-cardiac issues that we are often faced with in these patients is pregnancy, contraception, genetic counseling, something that we need to do. Quality of life may not be really ideal even in those who have been operated because of so many issues. Then functional exercise capacity, again, one can see that these may not be normal or optimal. Educating these patients for their problems is also very, very important. Employability is again a big issue. Even a post-operative ASD patients are sometimes not employed properly simply because there is a scar on the chest, and very often these are sent to us for review whether they can be employed in a meaningful employment or not. And then of course we do have psychosocial issues as these children become adults. Non-cardiac surgery is another big problem that often comes back to us asking for clearance for general anesthesia in these GUCH patients. So for us, the challenges are to decide on the operability. If you have a 15 or an 18-year-old with a large VSD, whether to operate or not to operate, managing their pulmonary artery hypertension, managing consequences of chronic hypoxia, counseling these families on lifestyle, marriage, employment. I think these are the issues that families often present to us. And then of course, in future, we are hopefully going to see more and more operated congenital heart disease patients. Now, I would just like to devote few slides on cyanotic heart disease because that's something that is not uncommon in our country. And when a cyanotic adult presents to us, I think these are the conditions that come to our mind. Epstein, Eisenmenger tetralogy in the ascending order. TAPVC, of course, is much less common, and often these patients actually go on follow-up as an ASD, simply as an ASD. So if you look at the natural history of tetralogy of Fallot, it's pretty bad with a 30-year survival of only 6%. And if you operate, then their chances of survival are much, much better, almost nearing the normal survival. Although a small percentage can have sudden death, and therefore one has to be following up these patients all the time. For Eisenmenger syndrome, actually the survival till the age of 30 is not bad, and it has been said that the mean age of death is about 45 years. In fact, life expectancy is reduced by about 20 years in Eisenmenger. So I think we all think Eisenmenger is a very bad disease, but it's not such a bad problem, especially till the age of 30, 35 years. Of course, after that they start deteriorating. And an unwarranted surgical closure, sometimes we say, all right, this patient seems borderline, so let's go ahead and operate, can actually hasten death in these patients. So they are quite balanced, and therefore it is best that we do not or we counsel them very well so that the policy of non-intervention must be followed unless absolutely necessary, and we should avoid destabilizing the balanced physiology. Hemoptysis is another problem that many of our patients present to us with, and generally it is considered to be a problem in tetralogy and tetralogy-like conditions, but in a study from our institute we saw that this was a problem even in those who had Eisenmenger syndrome. That means if we can look for aortic pulmonary collateral, we can actually block them, and therefore these patients will be relieved of their hemoptysis. Neurological complications in adults, we usually have brain abscesses, and we have to have a very high index of suspicion because any cyanotic patient who has a long fever, has no infective endocarditis, one should think about brain abscess. You may not get typical neurological features of vomiting, headache, etc. So one has to go for a CT scan to look for a brain abscess. Then there are lots of hematological problems in the form of erythrocytosis, producing high blood viscosity. And I think we should remember that iron deficiency can occur in these patients, although they are polycythemic. So if we are using iron supplements, we have to be careful, and it's good to do serum ferritin levels to see whether they are really iron deficient or not. They can also bleed, they can also thrombose, and platelets tend to be reduced, especially those who are severely cyanotic. Again, to use anticoagulants or antiplatelet, one has to be careful and decide on an individual basis. Phlebotomy is something we often talk about. Somebody having a polycythemia, we say, all right, this patient will get relieved by phlebotomy, but the indication is only if there are symptoms of hyperviscosity. And it is important to remember that symptoms of hyperviscosity can resemble those of iron deficiency anemia, and therefore these patients can actually worsen with phlebotomy sometimes. It is better to avoid repeat phlebotomy if you have done one before 3 months, and whenever we are removing or doing a phlebotomy, it is important to replace with the equal amount of isotonic saline or dextrose. Aggressive phlebotomy may lead to complication, and one has to be conservative in doing a phlebotomy. So when it comes to Eisenmenger syndrome, I think it is something that one has to deal with, and it is very, very important to educate the patient. And these are the triggers of serious events in Eisenmenger syndrome. Pregnancy being one, and of course high altitude infections, long distance air travel. So all that has to be educated to the patient. Arrhythmias are other problem that we see. As I said, even in postoperative ASDs, you can get arrhythmias. Postoperative other conditions, you can have blocks, you can have very sinister ventricular arrhythmias. This has been described in tetralogy of Fallows postoperatively. For pregnancy, I think counseling is very, very important, and we need to think about the mother and the fetus. Of course, mother takes precedence over fetus always. Most women with simple congenital heart disease can tolerate pregnancy with proper care, but it is the mothers with pulmonary hypertension and cyanotic heart disease who fare the worst with pregnancy, and therefore the chances of live fetus are quite low if the P saturations are low. In this study also, as you can see, the cyanotic and Eisenmenger syndrome, women had the worst complications in terms of their premature delivery or offspring mortality. So pregnancy is actually contraindicated. Maternal mortality occurs in as many as half of these mothers. Important thing to realize is that mortality often occurs in the first week after delivery, and therefore one has to be on the lookout, and one has to be very carefully watching these women. In fact, outcome of pregnant women with Eisenmenger has not changed much, and therefore it is absolutely contraindicated as of now. So to summarize, number of adults with CHD or GUCH population is actually rising, and it presents a significant challenge for many Indian centers, both to cardiologists, pediatric as well as adult. Group is largely constituted by unoperated CHD as of now, which have been selected by natural history. We do not have any GUCH specialists, so most of the time it is both of us, pediatric and adult cardiologists, managing them. It is likely to become a big problem in terms of post-operative GUCH patients, because we are going to have more and more surgeries, more and more centers have come up, and it is therefore necessary to come up with collaborative efforts to answer some of the questions, and maybe start by forming a registry of adult congenital heart disease patients. Thank you for your attention.
Thank you very much.